Good afternoon, everybody. Thank you for inviting me to be part of this event. I'm really so privileged and honored to be part of your activity today. I hope my presentation will add value and you will gain something out of it. I'm going to present the diabetic foot ulcer management from nursing perspective. So, okay, nothing to declare from my presentation. The outline, I'm going to present the challenges with patients themselves, how make them unique and difficult to deal with sometimes, a definition of hard to heal wounds, holistic patients assessment, covered mostly by Dr. Hani Badhdeh a while ago. Infection and biofilm, standard of care, and times versus timers and wound management. By the end of this presentation, audience will have more understanding why diabetic foot ulcers are hard to heal. And we will present some advanced solutions that might help in healing them. So challenges with the patients. Let's start focusing on the patient themselves. The most important things, as we noticed this morning, they came in complex condition or complex medical history. إنهم لا يأتون فرادى, and the most worst scenario, patients with uncontrolled diabetes, congestive heart failure, end-stage renal disease, and hemodialysis. So once you get this patient complicated with the neuropathy, diabetic foot ulcers, they will be so hard to heal. And they will take longer time also for the healing process. Patient adherent to the medical plan, sometimes it's so challenging and so difficult to convince the patient to have normal glycemic control, and to convince the patient that medicated dressing with advanced ingredient, that well-known ingredient and the sterile dressing is much better than herbal and alternative medicine. It's so challenging sometimes. Offloading, I can tell you, 95% from the patients, they will wear them once they are on their way to the medical appointment. Other than that, they will wear the regular and commercial footwear. So we have to help the patients. They can adhere to control blood sugar level and follow the dressing protocol provided by healthcare worker, and wear the foot offloading devices provided by hospital. Sometimes late seek of the medical advice, leaving the healthcare worker with no options other than amputation, and sometimes that's making the patients lost their trust between them and the healthcare worker. So we need to encourage the patients and their family to seek the healthcare advice as soon as they develop any red flag. So this also will covered by Dr. Hani Badhdeh during the screening and early intervention. Another challenge, late diagnosis or late decision may lead to delay in wound management as well. And we need to convince the patient this is lifelong management. So this is not once and will happen once, or it will be to be done one day and the next day we will go back to the normal life. So this is gradually need to be changed, our lifestyle modification, in order to be a habit, and we'll have new lifestyle with diabetic to control the complications. So once they develop the ulcers, they most likely to be hard to heal, and the definition of the wounds, the hard to heal wounds, the wound that fails to heal by 40 to 50% from size reduction during the first 4 weeks of standard therapy. Other terms, stalled wound or stagnating wounds or delay wounds. And hard to heal wounds tends to be replacement of the chronic wounds, because many people, they think that describing this ulcers by chronic wounds has certain types of negativity. So we want to be more positive and giving patients hope there is a chance for healing them. So they are not chronic, but they are hard to heal. So, as we mentioned earlier by many of you of the speakers since morning, early screening, early recognition for those who's at risk to develop diabetic foot ulcers, leading to early intervention and saving the limbs and preventing development of diabetic foot ulcers. Accurate assessment and diagnosis for the patients and for the wounds, optimal patients and wound management strategies, including multidisciplinary wound team. Starting from the endocrinologist and vascular and podiatry and interventional radiologist and wound management. Appropriately skilled healthcare professionals that they have to meet and to put all their efforts and strength and experience to heal the wound and prevent recurrence. It's really a challenge, and to create this team. Early referral for a specialist, as we mentioned before. When we had the assessment, we should perform holistic assessment for the patients, including physical, psychological, spiritual, and social needs. This might identify the underlying pathophysiology for the causes, and including the endocrine to perform the diagnosis and the start management, podiatry, vascular. Both these services are partnered to provide a high quality service for patients with diabetes that might develop diabetic foot ulcers. Risk factors screening and prevention is crucial, and this must be started from the community. So from the many of the literature said and recommended that from the moment that endocrinologists diagnose patients with diabetes, must highlight this many complications might develop as a sequences of uncontrolled diabetes. Example, retinopathy, kidney malfunctioning, and neuropathy. So prolonged neuropathy may lead to development of diabetic foot ulcers. So from that moment, that a prevention might be started. Once patients develop ulcers, that we have to measure and describe this ulcer and document it as a baseline. Photo documentation may support us for the subsequent comparison and to see where we are going. Are we doing good for this patient or healing this ulcers, or it's getting deteriorating? So plan of care including decide the desired outcomes. Are we going to salvage the limb, or we are going for amputation? Address and manage underlying causes and pathology, including the glycemic control, revascularization if needed, and infection management. Implement local wound care according to the wound bed preparation or types principles. I'm going to explain it shortly. And consistent follow-up and reassessment and measurement. Modify the care plan and refer as necessary for the specialist multidisciplinary team. Patient and family education should go throughout all this journey, and including the patients and the decision that will make them empower them and give them some responsibility, so that feel he is the part of this journey. We are not giving them orders to do and follow up our recommendations. So let's to sit with the patient and understand more his beliefs, his goals, and his objectives in treating his ulcers. Discharge and the transition to maintenance treatment for prevention recurrence is sometimes is very important, as mentioned by Dr. Badahdah earlier, and especially for after the prolonged admission for treating diabetic foot ulcers. Patients after admission, they will go, they are eager to go for normal life, but we have to instruct the patient, as long as you have this ulcers, you should have minimized the weight bearing in that affected part, and frequently using the movement aids as wheelchair or walker frame as much as possible. Record actions and outcomes at every episodes of the care and every follow-up to maintain the consistency of the patient care provided. Infection and biofilm, it's going to be a very mystery for the healthcare workers, because sometimes it's so clear to diagnose the infections once the patient has a clear clinical sign and symptoms of infection. I'm sure most of you are familiar with this bacterial load quantum. That's believed, many literature says that by default, all the chronic wounds by default are contaminated. They having bacteria, but the bacteria is inactive. So once they are multiplied and get colonized and have some showing clinical signs and symptoms of infection, by this time, the ulcer will be more exuding, more redness, might have non-viable tissue, patients may feel pain, the odor may appear. So at this time, we have to start the local antimicrobial medications. Once the infection spread to the bloodstream and patients showing systemic signs and symptoms of infection, a clinician must start the systemic antibiotics. Throughout this plus continue the topical antimicrobial dressing. Throughout this journey or this times, patients might develop biofilm. Biofilm, as we said, the bacteria will show signs and symptoms of infection when they are individual and in a planktonic phase. Once they aggregate, and they will protect themselves with polysaccharide shield that's very highly resistant to topical antimicrobial, even systemic antibiotics. The wound might be stagnated and not responding very well to the topical antimicrobial or systemic antibiotics. So we have to suspect the presence of biofilm and treat it accordingly. We mentioned that, and the biofilm cannot be identified by naked eye, so detecting and managing need experience and expert eyes. So biofilm has been recognized as a significant contributor factors to hard to heal status of a chronicity in the wound management. Also, it's known that majority of the wounds contain of biofilm, and critical to manage underlying causes to encourage healing process again. Time of principles is a systemic way and bundle that created by wound expert in 2002 to provide systemic way of wound management. So times indicating for T for tissue available within the wound bed, I presence for infection, M moisture, and E epidermal margins. So once the patient, the wound develop a non-viable tissue, we have to clean them up. So we need to debride by any means of debridement. The debridement method ranging from surgical to autolytic. Surgical is the most painful, expensive, required sometimes anesthesia or time and skillful surgeons. And that will put the patient at risk for bleeding, for pain, and might develop more access for infection. So sometimes we will go with very conservative. We will follow selecting some product to provide autolytic debridement, enzymatic or chemical, or we will perform mechanical debridement at the bedside for sometimes. Once the infection identified, we have to start using topical antimicrobials to treat the local signs and symptoms of infection. Moisture balance must be maintained. We don't want the wound to be too wet. That's creating chaotic wound environment. So the body cellulars will not be able to focus and perform their job to build up a new tissue and control healing process. And the margins, once they dried, creating the dry edges or callus formed, the edges will not be progressed toward healing or to contract. So we need to maintain them moist to have advanced margins for skin. And once the wound is stagnating and there is no progress or no sign and symptoms of healing, we have to give it more push or more posture. So we have to think about repair, and repair indicating by using some advanced technology or advanced materials that may give push toward wound healing or to disturb the wound environment, so that will create a healing process again. Some of this technology or methodology is still under studies. Many RC studies or cohort studies and undergoing to evaluate the efficacy of using platelet-rich plasma, growth factors addressing amniotic membranes used or bioengineer skin substitute, hyperbaric oxygen therapy, stem cell therapy, and electrical stimulation. So all these process or methods, advanced technology, they are so expensive, still under evaluation and under clinical studies. Only a negative pressure wound therapy has many RCTs and meta-analysis proven that it has well-established support and evidence-based practice to provide healing environment or healing process. So we have to study patients socially and saturate patient with education in each sessions, because they don't use the information we are giving them in their daily routine. So we want them to get them memorized and integrating all the information we provided in their daily routine. Some of the patients retain the information when they provide it in very simple language. So we have not to use any medical terminology. We have to simplify the information as much as we could to the patients. Some of the patients highly educated as engineers, but they are so much away from the any medical for the medical field. So if he started to speak about his specialty, I might be humble. I will not understand any word from his speech. So vice versa, please speak to them, to any patients in any different level of their education in very simple Arabic language. And motivate themselves and encourage them to be part of your treatment or of your journey. Once you empower them, they will have the lead of the journey. They will have more control, and the adherent for the medical journey will be much better. Understanding the belief for the patients, what they want to achieve, and also patient own goal, and patients and family and caregiver support. The family support is very important. The patient might feel the support from us, but when we are not with them all the time. So when they go to the community or their home, they will feel lonely. there is no help and they might get depressed and hopeless. So get them to identify one of the family members to be close to them and be continuous support for them. So the first case, I'm going to share two cases with you. This is a 74 years old male patient with history of diabetic, hypertension, right foot stump, post-transmetatarsal amputation, positive for heavy growth of Pseudomonas, wound size for the foot stump, 6 centimeters and a half, 8 centimeters and 6 centimeters to the plantar side incision. So because of the Pseudomonas infection, we decided to start with wood to dry dressing every 12 hours using 1% of acetic acid. Then once there is no greenish discharge, we stop the acetic acid and switch to negative pressure wound therapy for 6 weeks until the wound gets ready at this stage, get ready for successful skin graft. And the pressure setting we used for the negative pressure wound therapy was a continuous 120 millimeter mercury. Another case, diabetic, hypertensive. This is young patients and type 1 diabetes and control blood sugar level, bronchial asthma, kidney disease, and smoker. Patient unfortunately fell down at home where he developed right ankle fracture during the pandemic in 2020 when all the hospitals locked down. Unfortunately, no surgery done for this patient. He went to 3 different hospitals in Riyadh. Unfortunately, they didn't accept him. So because he is diabetic, they refer him to podiatry. A patient advised to use the 3D walker. And the size, or maybe he didn't receive full instructions or the size was not accurate for him. Unfortunately, patient developed a friction injury above ankle level, admitted to the hospitals with this size of the ulcer, not this size, it was covered with the dead tissue. This is once they received the patients for me and after the debridement. You can see how much is swollen and edematous. And the diagnosis was that diabetic foot. But when I received this patient, I was doubting, okay, this patient is diabetic, but with uncontrolled diabetes, and this is what making the ulcers get worse, but this is not exact characteristics for and locations for the usual diabetic ulcers. As you see from Dr. Haniba Dahdah, most of his the wound that presented by her for his patients below ankle level. So this is above ankle level. Through the history of the taken from the patients, he mentioned that story for the 3D walker and was not well fitted to his leg. That's why he developed this friction ulcer. So MRI, unfortunately, suggested osteomyelitis. Tissue culture also was positive for staphylococcus aureus. And when I received this patient, we started the negative pressure wound therapy immediately with topical antimicrobial sheet because of too much edema and the wound heavily exudating. And the pressure setting was continuous 120 for 4 weeks with antimicrobial until we reached to this status. You can see once the edema subsided, there is a cavity revealed that the ulcer reaching the bone, and the bone was fragmented actually. We continue the negative pressure wound therapy at this stage until we reach to this status, and the output become less. The wound superficial, the cavity filled up with granulation tissue, no more depth, and we discontinue the negative pressure wound therapy. We switch to the silver alginate with super absorbent dressing to have more control on the exudate. Until we reach this status, then we started the collagen dressing twice per week until the ulcer completely healed. You can see even the surrounding area much better, no more edema. In the conclusion, diabetic foot ulcer have created an ongoing global crisis that challenges the clinician while healthcare costs are increased. It's important to be proactive and identify the factors and potential barriers that stall the wound earlier on in order to have them managed as soon as we could. And management of patients with diabetic foot ulcers, it's very important and essential to be consistent with the basics wound management, and regular monitor and wounds and adjusting the care plan as necessarily is essential to optimize the wound healing process or outcomes. Thank you for listening.